Hello, everyone, and thank you, Philippe, for that very kind introduction. And it's a great pleasure to be with you all and on this very important topic. And my apologies for speaking in English, and I hope you can understand me okay. So, Philippe, I'm just going to share the screen. Is it okay? Can you see the screen okay? Can someone wave? Yep, very good. Thank you. Okay, so Philippe asked me to talk about early intervention and particularly focusing on early psychosis, but also maybe suggesting how that can develop into a broader early intervention strategy for all the diagnoses. And this is where we are. In Australia. This is our map of the world, but this map is actually in London, not in Australia, but it's the way we look at the world. So Philippe knows because he's seen it from that perspective as well. So early intervention, it's been very difficult to get early intervention established in psychiatry because of a lot of reasons, but psychiatry has had a very traditional way of looking at things. It's been a very pessimistic way, and it comes from really the neglect of funding and support for the treatment of the mentally ill. Created a lot of pessimism and negativity. And this quote from the Italian philosopher Antonio Gramsci sums it up. Why it's been so difficult. The crisis consists precisely in the fact that the old is dying and the new cannot be born. So we've had this resistance to the idea. But so what I'm going to talk about is how we slowly overcome that resistance. And it's taken a lot of leadership from around the world, and also the right conceptual sort of thinking. And one of the breakthroughs areas that I'm going to talk about is the ultra-high risk or prodromal focus, the at-risk mental state, which we formulated back in the early 90s. Then the second target for early intervention would be reducing the duration of untreated psychosis. And then the third target would be basically improving the quality of care once people are actually diagnosed so that the treatment is much more effective and comprehensive. And then I'll probably, if there's time, go into these other areas of the transdiagnostic space afterwards. So the idea is a very powerful idea. It's the idea of early intervention. It's just part of the landscape of clinical care in other areas of medicine, like cancer and heart disease. But in psychiatry, it's been challenging, as I said. But ideas are powerful, and this quote from the founder of the Royal Flying Doctor Service in Australia: "If you start an idea, nothing can stop it." That's sort of true, but it's also not true, because there are lots of ideas that are really good and powerful, but they don't get implemented properly or at all. So as well as having the idea, you've got to then make sure that it gets delivered in the real world. And it's been a long search, and one of the big problems we had to overcome was the pessimism that the Kraepelinian concept of dementia precox and later schizophrenia introduced into this area of psychosis. And it was based on the idea of people not recovering and not actually having good outcomes. And that was the unifying concept. And that's a very bad way to define any illness, as if you would define arthritis or cancer or any other area of medicine just around the concept of the people that didn't get better. You would not make any progress anywhere if you tried to do that. So there was a very big mistake. It's taken us over 100 years to overcome it. And the first thing we have to think about is can we modify the course of disease? And of course we can. With modern treatments, we can definitely change the outcome for patients. We may not be curing the illness, but we can definitely produce much better outcomes. And maybe by intervening earlier, we can even all of the disease. And but even if we just reduce the impact of the disease while it was active during the main years of illness, that would still be a benefit to the patients. Now, just starting off with the first area, the prodrome or the as we call it, we know that predict reasonably accurately the transition to psychosis, and we can even delay the onset of psychosis in patients. And that's, some people are still disputing that, by the way, and they're questioning the value of treating patients at this stage with psychosocial treatments, but we'll come back to that in a minute. The transition rate to first episode psychosis from this operationally defined ultra-high risk state is about a third of patients over about 3 years. Maybe a bit less in recent times, the transition rate's reduced, but it's still quite a powerful predictor. And of course, the converse of that is that most of these patients who meet these criteria don't progress to psychosis, so they are false positives. But still, we've got a very enriched sample for psychosis through this definition. And we're also defining a group that have a risk of other pathways to other mental disorders. So I'll come back to that too. So different pathways for this ultra-high risk state. A proportion transition to psychosis, others fluctuate within this subclinical psychotic state, and others go into remission, and others progress to mood and anxiety disorders and other disorders. So it's a very important concept. People have been criticizing this for 25 years and basically questioning the value of it. This is the latest raft of criticism. Some of these criticisms are valid. Maybe we're not finding enough of these patients at this stage of illness, and maybe but that's really a question of the platform of care rather than the concept. And the other issues that have been raised are we stigmatizing people by recognizing this early stage or at-risk state? The evidence doesn't really support that. There is some stigma, but we can reduce it significantly. And the benefits of patients being identified at this stage of illness from treatment really outweigh the risks of stigma. But we can go into that. And also, we can widen the channel. So in London, they can only find 5% of first episode patients en route to first episode via these clinics. But in Melbourne, we can get closer to 15-20%. So, and with the headspace model, we could probably do a lot better than that too. So this is really about the engineering or the infrastructure or architecture of how you provide care to patients at this very early stage. Of course, patients at this stage of illness have very significant problems already, even though they haven't met the criteria for first episode psychosis. Their GAF scores are in the 50s. They have a lot of distress, self-harm, and other features that really demand treatment. So we have to do something to identify them and treat them at this point. Some more papers criticizing it. Now, intervening at this stage, this is a meta-analysis from 2013, which shows that CBT in particular, but also other forms of intervention, mostly psychosocial, can reduce the risk of psychosis for at least 12 months. And in the Dutch research, they show that you can reduce the risk for up to 4 years. So this is a very significant thing, that you can delay the onset of the first break or the first episode. Now, other people, particularly that Fuser Polly and his group in London, have questioned this evidence using techniques like network meta-analysis, which, do actually show that no one treatment is any better than any other. But that doesn't mean that treatment isn't better than nothing. And they seem to have missed the point here. And this has ended up being a kind of a very arcane dispute between this group of people here and other people who have been working actually more directly conducting the clinical trials, like ourselves and the people in the Netherlands and other places, who believe that the evidence supports quite a significant benefit from patients receiving psychosocial treatment, at least at this stage of illness. So I'm sure many of you have seen these papers, but the basic message is that the treatment does help. It's not helpful for all patients, and it's not the last word because we do need to improve it, but it's certainly better than not doing anything or just monitoring the patients. So I think that's quite clear. Cochrane review also did not help. It was a very poorly done Cochrane review, which, came up with some very bizarre conclusions, like the best thing to do was to consider psychotic medications at this stage, which is the opposite of what the evidence actually says. So these people working in Croatia really confused the field, I think, with their very poorly done Cochrane analysis. And we were then prompted to write critiques of these meta-analyses and Cochrane reviews in Lancet Psychiatry and in JAMA Psychiatry. And it was a question that these evidence-based medicine techniques and the Cochrane approaches, they can't see the trees for the wood. It's the opposite of the usual problem where if you don't see the big picture, you don't come to the right conclusion. But here, the actual hard evidence from the clinical trials is being somehow disguised by these meta-analytic techniques. So it sounds like an academic debate, which it is. In the real world, helping these patients in a needs-based way at this stage of illness is extremely helpful to most of them. So to summarize this prodromal or clinical high risk or ultra high risk area, we have made progress in being able to identify a clinical phenotype with a need for care, which has a substantial risk of transition to psychosis. We know that the prediction can be sharpened with additional variables, but with falling transition rates, enrichment is an issue. We have to find ways to enrich the sample so prediction is more accurate. We can reduce this risk through the provision of relatively specialized psychosocial treatment influenced by CBT. However, there are other comorbid or emerging syndromes, which means that there's a valence for other exit syndromes, not just psychosis. And there are a range of other outcomes, including persistence or recurrence of the psychotic symptoms and poor functioning. And these need to be the target of new intervention strategies, which is the subject of US-funded research now. We need to clarify the sequence of optimal treatment for the ultra-high-risk stage. And ideally, this needs to be done in parallel with the prediction and treatment of other syndromes, not just psychosis. And this is about passing the heterogeneity of these cases. And you need to have a transdiagnostic perspective for this. And as I mentioned, this is the subject now of a huge US grant. It's up to $100 million US, funds two networks, one based from the US and one based in Australia, but involving people from across Europe and in parts of Asia as well as the US. So this project will, I think, increase the prediction power of this area, but also hopefully define some of the biological mechanisms underpinning this early stage of psychotic illness. So let's go back. This is a study that we did funded by NIMH called the STEP study, which looked at the sequence of treatments in this phase of illness, starting off with a very simple psychosocial intervention, then looking at the effect of more specific psychosocial treatments, and then ultimately biological treatments like antidepressants and psychotics later on. So this study is being analysed now and will be published hopefully in the next 6 to 12 months. The new study is really the $100 million study, which involves institutes from across Australia, Europe, and North America. Here are some of the investigators working on this at our end. It's led by Barnaby Nelson. I'm in those Paul Amiger, Alison Jung, Stephen Wood, and Andrew Thompson. They're the Melbourne-based investigators. So I talked about the pathway to other diagnoses. So it's not just psychosis that comes out of this prodromal definition. If you capture a sample of patients who meet the criteria for ultra high risk, maybe a third, maybe a little bit less will become psychotic. The rest, nearly all of the rest, will develop other mental disorders of some sort, mostly mood and anxiety disorders. So, and some people call them false positives, but they're not really false positives because they have a need for care. So this has been looked at by a number of papers, and it led us to publish this paper in World Psychiatry in 2018, trying to take us beyond the prototype of stage 1 psychosis or at-risk mental state, transitioning to a transdiagnostic approach. I don't know if you've seen this paper, but it's published in World Psychiatry 3 years ago. And so we started off with this idea of trying to predict psychosis, from this sub-threshold positive symptom stage mostly. And now we're looking at a much more ambitious project, which is trying to define the microphenotypes or the sub-threshold stage 1 cases that are at risk for a range of major macrophenotypes, which resemble the DSM categories that you see there: schizophrenia, bipolar, depression, personality disorder, and so on. So the basic idea is that the phenotypes that are captured by the DSM or the ICD in terms like schizophrenia are quite late phenotypes. They're phenotypes that, are preceded by months or maybe even years of sub-threshold symptoms before it becomes clear what's really wrong with the person. But it's not just one disorder that we're trying to predict, it's multiple exit syndromes, if I can put it that way. And it raises the question of how do people become psychotic in the first place? How do they develop a mental disorder? And how do you go from being well to being unwell? And you might start off with individual symptoms like insomnia or rumination. And you find that these symptoms act as risk factors for other symptoms, and they cause a cascade of risk. And you end up with a more coherent and stable syndrome a bit further down the track, which we might recognize as depression or anxiety or psychosis. But they don't come out of nowhere, and they aren't necessarily driven by biological change primarily. The biological change might be a correlate or a consequence of the symptoms. So the causal direction might be bidirectional. And just to illustrate an example of this, I don't know if I can, yeah. So this is using experience sampling data, which is very dense and frequent assessment of experiences and symptoms. If you do that over time, you might see different symptom labels. Sorry, I just go back. You might see the different symptoms changing in relationship to each other, which is how syndromes actually form. And I'll just show you that. So on the right, you see the symptom, the experience sampling data being collected, and you see that the correlations between the actual symptom domains changes over time. It strengthens and it weakens. So the symptoms of insomnia and anxiety and worrying, they kind of vary in their coherence, in their relationship to each other, and the strength of their relationship, and also the stability of their relationship. And to recognize a syndrome like depression or psychosis, you have to see coherence and stability. Those are the hallmarks of syndromes. And syndrome is an important concept because if you listen to psychologists, they talk about dimensional psychopathology, but it's true that psychopathology is dimensional, but you also have this concept of the syndrome, which becomes coherent and stabilizes as well. So this idea has been taken up in global mental health. The staging idea has become a very prominent part of thinking now in psychiatry, especially in this Lancet Commission in 2018 published on global mental health. And of course, we've used staging to try to make sense of the very bewildering array of biological changes that we see in mental illnesses, which don't really fit current syndrome concepts that well, but they may well fit the stage of illness concept quite well. Things like inflammation or, stress biology or chronobiology, or even lipid metabolism. These things might change according to stage of illness. And they may change to some extent by syndrome, but they may be more closely related to the stage of illness that we're seeing. So it's a heuristic way of looking at biological research. And if you want to read more about this idea, we published this book in 2019, and it's been an organizing heuristic principle for our research over the last 15, 20 years. So some authors have tried to convert that staging idea to the Procrustean silos of existing late macrophenotypes, like, let's say, bipolar disorder. But the essential feature of this model is that, at least in the initial stages, it has to be transdiagnostic. It doesn't mean that late macrophenotypes like mania or psychosis or anorexia can't be accommodated as they differentiate out and stabilize. But and the other point to make is that we try to license drug treatments according to descriptive syndromes and late macrophenotypes, but it's a spurious precision in a way, because these are descriptive things, and the actual biology, is different, and the medications are acting on the biology, which might be transdiagnostic as well, which explains why many of the medications, like even antipsychotics, work across diagnostic silos, and so do antidepressants. So the drugs have a broader spectrum of action than the FDA and these authorities might like to admit. So again, we've written more about this transdiagnostic staging idea, which the ultra-high risk or prodromal concept in psychosis is just an example of. It's like a prototype, which leads you to think, how can we actually understand, emerging illness through the staging framework, but also in a dynamic, ebbing and flowing type way of thinking about it. And this has been put into practice in Sydney, especially, also in Melbourne at Orygen, but in Sydney with Ian Hickey's group, and they published this paper in, I think it was 2019, in JAMA Psychiatry, which got quite a big sample of data looking at the transition from stages 1A to 1B, stage 1B to 2, in a transdiagnostic way. So it shows you how this concept can be applied in real life with real patients. Now, DUP, you probably don't recognize these people on the left, but they're the Democratic Unionist Party in Northern Ireland, and they're a very unusual group of people. But in the rest of the world, the duration of untreated psychosis is a correlate and probably a risk factor for poor outcome in psychosis. And we see this Norwegian slide here showing that when we do diagnose first episode psychosis, it's often after a very long period during which people have been, deteriorating and their lives and futures have been very badly harmed by the delay. And some people have died from unrecognized suicide or premature death. So reducing delay in treatment is a very high priority. The pathways, psychosis doesn't come out of the blue. There are a number of initial help-seeking and contacts prior to that in most patients. You're all familiar, I'm sure, with the TIP study in Norway, which showed that you could reduce the DUP quite significantly, and that would have a beneficial outcome, effect on outcome even after 10 years. It doubled the recovery rate. Now, of course, the recovery rate was still not great because the services had not been reformed to deliver evidence-based care for early psychosis in the most powerful way. So, but reducing DUP was a very valuable thing to do. I think this study from the UK shows that you haven't got long to get the maximum benefit from that. There's a curvy linear relationship. So you really have to find the patients in the first few weeks if you're going to get the maximum benefit from reducing delay. And the UK built this into their policy framework, saying that patients had to be treated within 2 weeks of recognition and diagnosis. And the effects of this data were strongest for waiting times longer than 3 months. So you had a loss of effect after that. This is real world data. It's not a research study. And in the US RAISE study, which delivered, protocol-based early psychosis care in a normal setting in the US, what they found was if the DUP was longer than 74 weeks, that early intervention care had no effect. So you had to find the patients in less than a year. Now, probably if they'd looked at it in much shorter timeframes, if the DUP wasn't so long like it is in the US, you might have been able to show even more dramatic results from very short DUPs or much shorter DUPs. 74 weeks is a very long DUP anyway. But probably the upside of that is that you can even get benefit from early intervention for as late as 74 weeks. So that's another way of reframing that data. But it certainly shows that DUP is a very important moderating variable on clinical care. And you should strive to find the patients as soon as possible after becoming psychotic. This is probably showing that DUP exerts an effect even in the long term, even when treatment is actually extended for 5 years after diagnosis. Now, that's some of the more research-based evidence about the value of intervening at the earliest possible stages in psychosis. But these next few slides are about the value of scaling up these reforms across the whole country, which can be done. And the IEPA, Philippe has been very heavily involved with this, and I hope you're all members of this. It's now called IEPA Early Intervention in Mental Health, so it's gone beyond just psychosis, but it was founded in 1997, so it's been going for 24 years, very important organisation promoting the networks and leadership in this space. We've got 8,000 members around the world, so it's probably the largest mental health organisation in the world in terms of, if you look at the Schizophrenia Society, the SIRS Society, it's got maybe 600 members. Maybe the bipolar organization's got a few hundred as well, but this organization has 8,000 members around the world. So very dynamic. The membership is free, so that's probably one of the reasons why it's got a larger membership, but it's a very important international network. First meeting was held in 1996 in Melbourne, and more recently it was to be in Brazil, but that was postponed. But the next one was going to be, we believe, in Singapore, and unless it gets cancelled because of COVID, but hopefully that'll go ahead. That will be number 13. We know that these reforms, these early psychosis services, have very good effects on outcome. Here's a meta-analysis from Christophe Correll on 10 studies that have been done with these services, showing very positive effects across the board for patients. And this research, the RAISE study and other related evidence, mainly from Europe, led the Americans to scale up early psychosis services in many parts of the US, funded by the US federal government. Of course, the Americans were probably 15, 20 years behind everybody else in doing this, but even in Europe, it's not routine to have these services. Although there are several parts of Europe where they are standard care. But it just shows that the scaling up of this model of care is starting to happen in America as well as in Europe and parts of Australia as well. The other value of these services is that they are very cost effective. They create mental wealth, as we say. You get a big return on investment for these studies over these services and reforms. And if you look at this slide, early intervention for first episode psychosis results in a 17 to 1 or 18 to 1 return on investment, which is probably not, if you look at some other studies, maybe not quite that high, but it certainly pays for itself many times over if you establish these services, because you reduce the amount of welfare payments that people need, you reduce the suicide rate, and you enable people to get back to employment and study, and they end up paying taxes, and so it pays for itself many times over. You reduce premature death. This study showed that in early psychosis services, the mortality rates were 4 times lower than if those patients were treated in standard adult mental health services. So you have to create the right culture of care, which is a youth mental health culture,
and the patients do a lot better, and they die at a 4 times lower rate. This is just a review paper we published a couple of years ago, capturing all of this evidence that I'm telling you about today. Now, of course, evidence like we've painstakingly produced over 25 years or so is necessary, but is not sufficient for reform, because reform is difficult. So why is that the case? Well, first of all, it's hard to reform when the whole mental health system is under-resourced and there's a neglect of mental health care across the system. In most parts of the world, that's the case. That's what that Lancet Commission on Global Mental Health showed a couple of years ago. Only 2% of health budgets around the world are spent on mental health care. So you see neglect everywhere. And that means the people who are treating the chronic patients are struggling to get enough resources, and they question the value of early intervention in a bizarre sort of way. Even though the argument, like in cancer, is you treat every phase of illness appropriately. You do prevention when you can. You do early diagnosis as a premium, and you treat people properly in the mid phase of the illness. And if you have to go to palliative care, you do that properly too. In mental health care, we're pitted against each other. Different groups of patients are basically, there's debate about who is of more value, and that's very destructive. And we've had, even though the evidence has been very, very powerful, we've had academic psychiatrists campaigning almost in journals against early intervention. It's bizarre. You would never see that in cancer or heart disease, but we see it in psychiatry. The pessimists and the vested interests to get together and try to undermine the whole project. Mostly they've fallen by the wayside over the years because the evidence has just been too compelling in the end in favor of early intervention, which they should have thought of in the first place, because it's hard to imagine why early intervention would not work in psychiatry if we've got effective treatments. So other threats to the reform are poor model fidelity, devolved and commissioning that doesn't support standardization of care, weak financial models. In the UK, they made a big mistake of diffusing the early intervention services across the whole lifespan, and that undermined the youth culture and weakened the resources that were available too. Probably. And the other challenge is mobilizing political will to support these reforms. So we've tried to counter this. We've tried to change the minds of psychiatric critics and try to explain why they think the way they do. But, some people are so rusted onto their views, it's very hard to change their mind. But we do want to try to change the silent majority of people who are willing to consider the evidence on maybe a bit conservative and slow to change, but are not a lost cause, I suppose. So the papers like this we published last year are trying to do this. I'll skip the bipolar bit. Hospital in the home is a new model of care, which is really a revival of an idea from the 1990s, which is basically home-based care for acute psychotic episodes and for other presentations. But it's now called hospital in the home. And it's kind of capped. A number of cases are capped, so you can protect the resources to make it really work. And it's working extremely well now as an alternative to inpatient care. How do we improve the quality and the effect of early intervention? Here are some of the things we can actually do. We can widen the entry channel for the ultra-high risk state and allow any young person that's struggling with distress or functional impairment or, a desire to talk into the front end of mental health care in a primary care level. So I'll talk about that in a minute before I finish. We can reduce the DUP to a matter of weeks through community education and detection teams, as they did in Norway, and we do that in Melbourne too. That's a very powerful thing to do. Another thing that is very neglected is early use of clozapine. If the person is showing treatment resistance in the first few months and the symptoms of psychosis have not resolved from a first psychotic episode, and clozapine is definitely indicated at that stage, you might be able to treat the case more effectively, even with a very low dose of clozapine if you use it early enough. And that's something that's The average delay to time to starting clozapine in most countries is about 4 or 5 years, and you may well have missed the boat in terms of the effectiveness of clozapine by delaying in that way. Of course, clozapine can be used safely with the monitoring and all the other things that go with it. Stage-specific care for early psychosis. You treat according to stage, and the treatment is tailored according to the stage. It's not just more treatment at the early stage. It's actually much more attuned to the developmental stage of the patient and the stage of the illness. That's what early psychosis services do differently from standard services. We need to focus in a holistic way on their physical health, their sexual health, substance abuse issues, family support, and vocational recovery interventions. All of those things should be part of an early psychosis service if we're working with young people in the early stages of illness. I mentioned mobile treatment and home-based assertive treatment. We need to look after patients for at least 5 years after entry, not 2 years, because a significant subset will have a more protracted illness and will not be in a really great shape until that 5-year period is over. And then the people with more treatment-resistant or chronic illness can be treated in a different stream beyond the 5-year period. Augmentation of care with online and digital therapies, and our MOST platform developed in Melbourne is a key feature there, key resource. And then whether we try to reduce the dose in a subset of patients that have had very good remissions early on, that's an area of ongoing research which is not really clarified. When do you stop or reduce medications after a first episode? Early intervention is a general principle in healthcare, so that's why the IPA is now calling itself early intervention in mental health, not just early psychosis. This journal that we started 14 years ago has really helped to catalyze the field to conduct research in other diagnostic areas and across the diagnostic spectrum in psychiatry. It's going to be published 1 issue a month now. It receives a huge number of papers these days. Its impact factor has gone up. So that's really helped the field to develop scientifically. And the field is moving from early psychosis to youth mental health more broadly. And you can read about that in Ashok Maller's paper here, published in, I think, 2016. Because mental illness and mental health is the #1 threat to young people's lives and futures. From the puberty through to the mid-20s, the adult-type mental disorders all emerge strongly for the first time, and 75% of mental disorders appear by the age of 25. This is a major threat to the mental wealth of societies, in other words, the social capital. And if we invest heavily in young people getting to the threshold of adult life, which they do in the early 20s, and they either die from suicide or they have a breakdown and become disabled and go into welfare, or even if they underachieve, the cumulative cost of that for the whole society is huge. And the neglect of proper treatment for these young people with mental health problems is a preventable source of loss of GDP and loss of productivity, apart from loss of human potential. I mentioned the age of onset of mental disorders. This is a book that we published a couple of years ago, led by Giovanni Girolamo from Italy. And this is what it really shows, that the onset of the major mental disorders of adult life starts around puberty, peaks in the early 20s, and it's the main health condition of young people, and even middle-aged people too. 75% of mental health problems have their onset in young people aged, or it's actually not quite true, from childhood right through to 25. And many of them perhaps are in early adolescence and late childhood too. Developmental trajectory for young people has changed. So people don't mature and become fully independent adults until their mid-20s in many countries. The current service system is really a pediatric adult system dealing with little kids and older adults. It doesn't really do well in teenagers and young adults for anything. So we need to strengthen the system for that age group. It's the peak need for care in mental health, and young people have the worst access at that point. And there's the loss of lives, futures, and mental wealth as a result. This is a great paper by Moffat and Caspi, published in 2019. And basically it shows that young people are at risk for physical health disorders later in life, as well as the mental disorders early in life. So we really need to focus on the people who develop mental ill health during this transition period. And there'll be a lot of benefits for, not just for mental health outcomes, but also for physical health outcomes too. The maturational development of young people is affected if they do develop mental ill health. They get developmentally delayed. And that is another argument for why you should not have a hard cutoff between child and adolescent systems and adult systems at 18. We need to have a youth mental health system that covers the period from puberty through to the mid-20s. And maybe a younger children's system for the primary school age kids, and then a system for the older adults over the age of 26. And that's what we are developing here in Victoria and across Australia as well. We're moving to that system very strongly. A number of countries are doing this. This is covered in this issue of the Medical Journal of Australia in 2017. Probably a dozen countries are embracing this broader primary care youth mental health model, which really is the best setting for diagnosing and recognizing prodromal psychosis, because people come in a stigma-free way, seeking help for distress and needs, and you can recognize the emerging psychosis patients within this broader spectrum of young people with mental health problems in a very youth-friendly culture. So we've developed this model across Australia. It's called Headspace, and probably about 35–40% of the young people coming to these centres have subthreshold psychotic symptoms, and the rest have other clinical pictures. This is our Prime Minister in Adelaide in Australia launching a Headspace centre. We will have 164 of these centres by the end of next year. We currently have about 150 of them, and they've all been developed in the last 15 years. So we've scaled this model of care up, a simple primary care model for young people across the whole country. Our Prime Ministers, these are a collection of our Prime Ministers over the last 15 years. They've all been very supportive of this reform and this model of care. Around the world, we've also got traction with the World Economic Forum, and this is in Davos. Originally in 2019, they made mental health a major focus for going forward, and they contracted with us to produce a project around global youth mental health, which we launched in Davos 2020, just before the pandemic struck. It produced this global framework for youth mental health, and basically a model of care that could be delivered anywhere in the primary care setting. So this is showing where the young people in the world actually live, mostly in developing countries. And this is, we did a consultation in all these countries that you see there around how to develop a model of youth mental health care. I'll just show you some of the early examples of this model, which was already happening before, by the way, like Jigsaw in Ireland, the Foundry in Canada, At Ease in the Netherlands, Headspace in Denmark, Headspace in Israel, Maison des Adolescents in France. And the principles are that you can define principles describing how this teenage and young adult service should look. Basically, a primary care idea has to be tailored according to local cultural factors and also local financing, health financing factors too. But there's no reason why this cannot be in every country in the world, because even the middle-income countries can afford to do this. And in some ways, the low-income countries can too, through technology and other sorts of strategies. We're producing a commission on youth mental health with Lancet Psychiatry, which will be published hopefully next year sometime. And so this is like a movement that we're creating, which is taking the early psychosis prototype, and particularly the ultra-high risk idea, into a much broader space with much more potential for I think, radical change in the way mental health services are developed, and with young people right at the front, at the top of the priority list for the reasons I've talked about. So I hope I didn't go too fast with this talk. I'm just going to unshare the screen and be very happy to take any questions or any comments that people would like to make. Covered quite a lot of ground there, but I tried to show how early psychosis has been very important as a prototype for even more significant reforms in mental health, which are based on scientific evidence. So thank you, Philippe, and thank you to the audience for your attention. And back to you.